Okay, so this is the basic teaching outline. This is kind of the format that we're going to follow. I'm going to try to stick to this. I did not make you copies of these, but I'll try to stick with this. I'm going to start off with a patient case, kind of just to illustrate the ability that we have in virtual care and get us thinking along those lines. We'll talk about some drivers of patient virtual care. Pitfalls, then I'd like to get some of your own experiences, if you've had experiences either as a patient or as a physician, and kind of just have an opportunity to discuss that. Then we'll talk about some really important components to success in virtual care, how to navigate virtual visits with our own program, which is Amwell Now. And I want to get you all set up and rolling on that. The MAs are going to be coming here about 30 minutes from now, and you guys will be able to kind of work with your MA, pair up and talk about some of those workflows. Lastly, we'll cover staffing, how to communicate with others, including behavioral health, in order to perform a warm handover. So I'm just going to go ahead and jump in with the patient case. This is just a patient case that I heard about that happened about a month and a half ago. And one of our current third-year residents had a patient on his agenda, on his Cerner schedule, that said, it said either scrotal mass or something along those lines. And so that particular provider was like, how am I going to do virtual visit for this? This is going to be interesting. And so he was just sharing the story of that visit, how it unfolded. He was able to get a really thorough history from the patient. He was able to use the patient, in the exam, and the patient was able to describe what that felt like, and essentially was able to diagnose varicocele. So, I share this example to say that things are not always what they seem, and that we have a lot of tools that we may not think of right off the bat, but that we can kind of incorporate into our virtual care and be able to do quite a lot. And another kind of case in point is I have a family that I take care of, and the mother came and said, hey, my daughter's been seen at the college health service twice for this sore throat, and she is not getting any better. And I'm really concerned about her. She's having high fever. She sent me this picture of her throat and showed me the picture of the daughter's throat. And that I was able to look at that picture and say, oh yeah, I think this is a case where we definitely need to trial another antibiotic. The first one didn't work. And I share that particular case because that happened about 6 years ago, way before we were doing televisits in any form officially through the clinic. And so I think there's always been a demand for that, for the access to physicians. And any way that we can expand our patients' access to the physician, I think that's a positive thing. So that segues into drivers of virtual care. Obviously, patient access is one of those drivers. They want to talk with their physician. They want to be able to have care by their continuity physician whenever possible. And telemedicine is a tool that sometimes enables us to do that. Sometimes patient safety can also be a driver. It may be that, particularly in this pandemic, I think that is one of the big drivers that, we say, hey, you are someone that maybe is high risk, or we just don't want to have 50 people sitting in the waiting room, all coming in here for live visits. Therefore, we want to try to do as much virtually as we can. And that cuts down overall exposure, cuts down overall risk of COVID. And in the similar vein, provider and staff safety. And you might say, well, gee, we've had our vaccines now. A lot of us have been vaccinated. I just got my second dose Wednesday, and feel pretty good, thankfully, knock on fake wood. So you say, well, gee, now that I'm vaccinated, does that risk go down? And the truthful answer is we don't really know yet. The initial studies, of course, what we've been hearing is they're 94 or 95% effective at preventing COVID symptoms, but we don't know if we are seeing asymptomatic carriers. We don't really know all of that quite yet. And the vaccine's new enough, we probably won't have that data for a while. We think it is definitely going to be a good thing, but we still want to have precautions in place. So pitfalls of virtual care. There are a few. I have at least one patient who has no access to Wi-Fi and does not have a smart device. So I think that we're all going to have patients who just really struggle to do a virtual, particularly with audio and video virtual visit. There are potential times where a patient might be driving down the road and, oh, it's time for my visit. And so you have to be wary, you have to be watching for that. And obviously we don't want our patients to be driving while we're in a virtual visit. Patients who are not currently in state. This is an interesting debacle, and the issue is really twofold. One is that you are licensed to practice medicine in the state of Indiana. Licensing is state specific. And if the patient is not currently located within Indiana, that you're licensed to treat patients in Indiana. There's some outdated language in our state's licensing laws. And there's question about how does this pertain to patients who are outside of Indiana. And similarly, medical malpractice, med mal coverage is for the state of Indiana. Here in Indiana, we pay actually IU Health pays your med malpractice, but when that purchase is made, it is something that covers you for the limits required by the state laws, the state of Indiana. And there's payment that goes into what's called the Indiana Patient Compensation Fund. One of the reasons why medical mal is so much lower cost in Indiana is because there's a very thorough peer review process. Before a case can go to court, it has to go through a peer review process. And what pays for that is the Patient Compensation Fund that also helps to offset costs of success of actual malpractice cases. So when you have a patient who's physically located outside of Indiana, the laws don't cover for that. They don't really say that your license applies, that your med mal applies. And there's a group right now that is looking into, in fact, they're called the Virtual Care Legal, Regulatory, and Revenue Cycle Subcommittee. Aren't you glad you're not on that? And they are working on figuring out an analysis of physician licensure requirements and med mal implications by state. And they're trying to get us more thorough information. Like, I have patients who snowbird in Florida. They would love to see me virtually, and it would be easy for me. It would be any different for me. So we just need to figure out those implications when it comes to med malpractice. Other pitfalls of virtual care are the lack of privacy in the patient environment. This is something that Dr. Rainey pointed out to me and is probably more germane in the behavioral health world. But if your patient's in their home environment and maybe it's a blended family, there's a lot of other people in the home, who else is hearing them discuss their condition? And are they okay with that? Now, you could take the argument that, well, it's their environment, they're in control of their environment. This is not my thing. But at the same time, as a physician, you just want to be a little bit sensitive to that. The next thing I put down here is patients not feeling heard or seen, or just the perception of less thorough evaluation. And this is something that with proper skill application, I think you can really offset, you can kind of accommodate for this in the virtual environment. And that's part of today's goal, is to really talk through what are some of those telemedicine skills that help you achieve a successful virtual visit. Inconsistently obtained vitals. I will say that hardly any patients, and I've been doing virtuals for a while now, hardly any patients take it upon themselves to get a set of vitals. Frankly, a lot of them maybe don't know how to do that, but a lot of my patients do have home blood pressure cuffs. A lot of my patients that are diabetic have glucose meters, and they have tools available that they can use to get some of that information. So we'll talk about that. And then barriers toward the physical exam, which is kind of obvious there. So those are some of the pitfalls. Kind of been on actually first I'm going to talk about the 4 habits model. This is on the back of your handout. This 4 habits model has been around for at least 20 years. We at the residency have been teaching it since I was a resident here, which is coming up on 20 years. So this is not new. And I really recommend that you incorporate these 4 habits: invest in the beginning, elicit the patient's perspective, demonstrate empathy, and invest in the end. And I've included this because these still apply in the virtual world as well. These are things that we've been teaching for the live clinic world for a long time. They also apply in the hospital setting, and they apply in the virtual setting. So I'm not going to go over every one of these, but as you go through the residency, doing tape reviews with Dr. Rainey and other things, we use this model to teach. But building on that, back to the front of your handout, I've included some similar skills that are specific perhaps to telemedicine, or at least things that we want to highlight within telemedicine. I'm just going to go down the bottom. So from the top of the sheet, you see the site listed there for Amwell Now. So if you've not used Amwell Now, that is the address that you can navigate to. It's pretty easy to get to. If you have not registered, or if you're not able to log in despite having registered before, what you do is you just re-register. You just go through the registration process. It takes a minute or two. It's really pretty easy, and it is a self-registration thing. You don't need to submit a SOLAR. You don't need to ask anyone else to register you. You literally just go through the steps. It's pretty easy. You will need to create a 4-digit PIN. That 4-digit PIN is your access to Amwell Now. It is what you use to start a visit or to schedule a visit in the future. That PIN, again, if you forget it, you just re-register. That resets your account. So on this chart here with telemedicine skills, I want to kind of go through each of those briefly. We'll hit those at a high level. The first is confirm patient identifiers. Now, if you know your patient well and they're connected with audio video, you can see, okay, I know that is my patient. If it's not someone that's known to you, it's a good idea to confirm that you have the right person by their name, their date of birth. Just, hey, I just want to take a minute, confirm that I'm talking to the right person, that I have the right chart open. You know, it would be devastating to go through an entire visit documenting on the wrong person or in the wrong chart. So take a minute to do that. Also, it's a good idea to confirm a callback number in case you get disconnected. Now, frankly, with Amwell Now, they got a link to the visit in their phone or in their email. And so what you could say is, in case we get disconnected, please just reconnect with the link that you used to connect originally. Or, you know, please just go back to the link that you received from us to connect. And then the last thing under this section is confirm the patient is in a safe location, mainly not driving. Like I've had several virtual visits where I can see the patient is in their car. And so I'll always just check with them. I'll say, are you stopped or are you driving? Are you in a safe spot right now to talk? And the patient, if they're pulled off to the side of the road, or if they're just sitting in their car in a parking lot, that's fine. But you don't want them to be driving down the road. In fact, our IU Health legal and compliance department has weighed in on that, saying if a patient is driving, please do not conduct a virtual visit. That's putting ourselves in danger of liability. The second skill is use effective nonverbal communication. Nonverbal communication is a little different when you're on a virtual environment. So you might see me sitting here, I'm kind of using my hands a little bit. Primarily, I'm keeping my hands low. They're not in the field of view of the camera. If I'm talking with my hands a lot in front of the camera, that can be a little distracting. At the same time, when the patient is talking, it's good to give nonverbal feedback to the patient, such as nodding to indicate, and eye contact to indicate that you're listening. Eye contact is a little different, and you guys are probably better at this than us old coots, but you know, eye contact with the camera. So it's a very artificial thing, looking at the camera and not actually looking at the patient's face. What I tend to do is go back and forth a little bit. I don't stare people down in the real world anyway. I don't like stare into their eyes the whole time. So I try to make eye contact with the camera, and then balance that by looking at the patient sometimes. And occasionally I'll glance at me just to make sure I don't have a stupid expression on my face. So it's okay to move your eyes around, similar to when you're driving down the road, your eyes are scanning the different gauges, but your eyes are primarily on the road, right? So in virtual medicine, your eyes are primarily on the camera, but you're also glancing around at the environment. The third skill is actively optimize technical aspects of the virtual encounter. And this is, Dr. Burns gave us a good run through of this, troubleshooting this, because it was hard to get connected in the first place. When you did, you couldn't see the patient. And so you had to kind of walk them through how to turn on their video. And that can be challenging. Most of us have a type of device, and we're not experts in all the different devices. So it can be really hard to walk through that. But just trying to help troubleshoot. Some patients are going to be super, super savvy with it. And I had one yesterday. He's like, oh, wait, I can't see you. And he's like, just a minute. And I was like, okay. And so I just kind of didn't have to do anything. I sat there and I gave him a minute. And he had it all figured out. And he got us up and going, and that was fine. It is a good idea not to assume just because you can hear and see them, though, that they can see and hear you. So it is good to ask, how is the sound? Can you hear me okay? When I am using the computer's mic, as I am right now, I ask the patient, is there any typing noise or anything that's distracting? And let me know if there is. We'll make an adjustment. Okay. The fourth skill, exhibit comfort and confidence using video interface. It can feel really weird the first few times that you do this, and it might make you feel fumbly or lacks in confidence in the visit. It's important to try to gain confidence in that. You can do that through, if you're struggling in that area, one of the tools is to do a few test runs. I know when I was starting out, I did a test virtual visit with Dr. Rainey twice. And it was just kind of good just to get the feel of the program, where to click buttons and stuff like that. So feel free. I know we're all in different seasons. He's in a particularly busy season right now with interviews. But feel free to reach out to any of the directors or a peer or a spouse, whoever, and do a virtual test run. Okay, the fifth skill is utilizing live video to augment information gathering. This is one that I think we can really all pay attention and grow in some of our, what we have available to us. I think we tend to just skip the physical exam. And actually there was a study on this. I found a study in the Journal of Graduate Medical Education. This was published last month, December 2020. They studied about 78 residents. Now, these were internal medicine residents. So had they studied family medicine residents, it probably would have been a little bit better outcomes. But they found that residents typically did a very good job with information gathering, taking a history, with relationship development, and with education and counseling. They did a pretty good job. But they really struggled in some of these telemedicine skills that we're going over today. And in particular, some of the ones that they did the worst on were using, actively optimizing the technical aspects of the encounter, using live video to augment information gathering, and partnering with the patient to perform a physical exam. So that was, those were areas that they identified for further development. And they actually created an OSCE for a virtual visit, which not planning on doing an OSCE today, but again, doing it on your own with a practice run could be very helpful for you. So gonna talk a little bit more about that, using live video to augment. So one example of something you can do, which I listed out here for you, is you can reconcile the patient's medications. Ultimately, I would like us to grow MA involvement, and that the MAs could do that process, but they're not doing it today. So if you've got patients and they're on 15 medications and you're kind of worried about polypharmacy and interactions, it's a good idea to try to reconcile those medications with the patient. And they should be able to put it up in front of the camera and show you the medicine, and you can go through one at a time or however you need to do that. Try to witness reproducible symptoms. If the patient is complaining of a cough and respiratory symptoms, ask him to cough. Ask him to recreate any symptoms that they can. And another thing I put in there is talking with an on-site collateral person. Patient is older, has mild cognitive impairment. Talk with them. Talk with their caregiver as well, as a way to augment information gathering. And lastly, you can assess the home environment. You can, depending on the situation, if it's a patient, you can have them walk you around their home if they're comfortable doing that. Say, I just want to do a little safety check around your home. Would you be game? They could walk you, give you a little tour of their home. Those are all ideas for augmenting information gathering. The seventh skill here that we're going to cover is partnering with the patient to perform physical exam. This is a little similar to the last thing, but how can you get physical exam? The example I led this discussion with, where the resident had a chief complaint of scrotal swelling. You think, oh man, how do I do that virtually? And that might be a more challenging thing, but depending on the complaint, you can't listen to the patient's lungs, but you can listen to their breathing. You can have them breathe out forceful exhalation. You can gauge their expiratory phase. You can hear if there's audible wheezing. You can have the patient feel certain parts of their body. You can have them check their pulse. Any other ideas? Anything else you guys want to? So yeah, good question. So are there areas that we would say don't look at over the? It gets back to the patient's environment and privacy. The technology that we're using, namely AML now, is HIPAA compliant. So there should not be risk of concern as far as privacy or sensitivity with regard to the technology itself. So it really comes back to the patient's environment. And if they're comfortable, they say, hey, I've got this rash, it's kind of down here. Is that okay to show you that? That's okay, as long as they're in an environment where they have privacy to do that. And similarly, where you're in an environment that's private. I would say that if you have the capability to do virtual visits from home, technologically that is available. With the public health emergency and the waivers and the flexibilities that are offered through that, we as providers are able to conduct virtual visits from home. When the public health emergency ends, that may revert back to say, no, providers really need to be in their office. But as of right now, they could be done from home. So it's important also that your environment is a private environment. We have 12 extra monitors here in patient exam rooms. They're some on B side, some on A side, and that was set up specifically for people to do virtual visits. A dual monitor is really nice because you can have the Cerner record up on one monitor and the patient up on another monitor. And so my advice primarily would be try to find one of those exam rooms, and you only need one room. So the nice thing is that, there are people in clinic, but you only need one room. So you're not taking up a pod. So we should have enough space where if you're doing virtuals, 2 or 3 in a row, you could just snag one of those rooms, set up with a dual monitor, just plug in, and you can slide Cerner over to one and the patient on the other. Having done these for a while, I kind of like to put Cerner up on the main screen with my camera right here and the patient's off here to the side. And so that allows me to be looking more at Cerner and to be navigating and documenting and still be close to the patient and be able to just pan up to see them make an eye contact with the camera. It is a little bit odd though, because the patient's talking over here. And so I've gotten into this habit where when I'm opening up the visit, I'll say, now, just want to let you know, I'm working with 2 monitors and I have your chart up on one and you on the other. In case you see me look over here to the side, that's what I'm looking at. I'm not glancing out the window or anything like that. So I just kind of give them that little warning. And I've got it, when I deliver it that way, they usually chuckle and laugh. It's oh, okay, it's kind of a good way to start off the visit. And don't forget to get vitals whenever you can, whether it's a smartwatch or a blood pressure cuff that they have at home. Try to do that. And again, we're working toward having our MAs build that into their workflow. This is all new to them, right? So this is a growing process for all of us. But the hope is that the MAs would start the visit, would reconcile the meds, eventually would take vitals or whatever vitals we can get, and then would lump you guys in, okay? Lastly, we want to maintain appropriate computer etiquette. And so that's kind of like, you know, if you are pausing, let's say the patient just gave you something and you're like, man, I really need to document that because there was a lot of details in there. And it might take you a little bit longer. You might say, hey, just pause for, if we can pause for about 30 seconds, I want to catch up and document some of that you just told me. And that prevents there from being this awkward moment where they're like, are we still connected? You know, did it freeze? You can just say, hey, I just want to document a little bit of that. And if you, like yesterday, I was talking to a patient and we started talking about a medication. I said, you know, let me just double check and verify the dosing on that medication. If you don't mind, give me a second. I'm going to pull it up on another device. And they're like, oh, okay, that's fine. And so they're watching me do that, you know, while I'm checking. But it's not like I just whip my phone out and be like, you know, while we're on the visit and they're not sure what I'm doing. So that's important to give them some context clues. They can't see exactly what's going on. They really only see a little bit of you. You need to give them a little context as far as what you're doing. Okay, last things on this sheet, and then we'll talk about Amwell real quick, is to perform a warm handoff. So both warm handoff and staffing both involve pulling in another individual to the visit. Staffing doesn't always require the attending to see the patient, but when it does, it's almost like a warm handoff. So those are pretty parallel in how you perform those actions. The first thing and the biggest barrier that we need to work on is how do you figure out who to pull in? Especially like if you're here in the clinic, you can walk to the staffing room, you can walk to the behavioral health room and say, hey guys, who's available? And that's what we do in person now. But what would be ideal is if you're in A12 and you've got everything set up, it'd be ideal if you could jabber someone. If you're at home, it would be ideal if you could message someone, hey, I've got a warm handoff. And again, we're not doing them a lot from home, but there is that capability, right? So we're still working through how does that work? How do we know who to jabber? How would we know who to contact? So the most reliable workflow for the present time would be to walk to the staffing room or walk to the behavioral health room, recognizing that's not the most efficient workflow, but that's kind of where we're at in this moment. So, and then the key thing there is just to explain to the patient what you're doing, ask for permission to pause the visit, and that it might take, for the instance, either way, handoff or staffing, if this might take a few minutes for me to locate that person and get them plugged into your visit. You are all beyond the 6 months of initial training, so you don't automatically have to have every person seen. And that's a real pro. And most of the patients that we're conducting virtually are usually low complexity visits. So most of these folks won't have to be physically seen. If they do, if they do need to be seen, or you have a question, you're not sure how to navigate, you're gonna want to either pull up the staffing schedule on Google Calendar. It might be good to know who's in there before you start your clinic for the day. And you might wanna send them a diag notes and say, hey, I'm on a virtual, I need to staff this patient. Can I staff with you? It's possible to connect with them over diag notes, audio visual by your phone. And they're on your phone, you can see and hear them, and it's possible to do that all in one visit. You can also pull them into the Amwell now. And then they will connect directly into the visit in Amwell now. And that's pretty easily done, but you have to know, again, you have to know who to contact, right? Because if I'm over at the hospital rounding and you contact me, I'm not going to be able to just jump on and get an Amwell now very easily. All right, so with that, we want to pull up Amwell. And I am sharing my screen up here. And the way that you get to Amwell Now is this address right here, iuhealth.amwellnow.com/, and I don't think you have to type the /now. If you type that in, you will be, it will pull you up to a screen that looks kind of like this. I am registered, so it's showing me my start screen. Again, if you're not registered, you're just going to have to create an account. Down here at the bottom, it gives me the option to create a new account. So if I forgot my PIN, that's what I would do. I would just say create account. It doesn't matter that you're already registered. It will just redo your registration from the get-go. That's fine. All I need to start a visit now is to know the patient's either mobile phone number or email address. I kind of need to know how they're going to connect. So ideally, when our schedulers make the visit, if it's pre-planned, they're going to know the patient wants to connect by email on their computer or through a text message, and that will put it into their phone. Most of the ones I've done, actually all of the visits I've done in Amwell Now, I have just put in the patient's mobile number and we've done it on their phone. And the patient, when I do that, I'm going to show you what I do here. I'm going to put in my PIN. And I'm going to put in a patient's mobile number.